so much, Amy, for that introduction, and good morning. It's good to be with you all. I am a services researcher. I'm not going to talk about services research today. I'm going to talk about the Autism Data Science Initiative and give you a sense of how quickly this came together and what we hope to accomplish with these grants. So the normal process for coming up with a request for applications or a notice of funding opportunities at the National Institutes of Health is longer than this. It often takes years for those things to be written, for them to be vetted, for them to be put out, and to ask for applications. I think one of the things that happened here was, as you saw in the pictures before, that Secretary Kennedy announced that in September we were going to know what caused autism. So he walked that back a little, and so the idea was then these applications were going to be funded in September, and so that science was going to start. So this initiative was announced at the end of May in 2025. Applications were due a month later, which is the fastest turnaround time for an NIH mechanism that I had ever seen. There was review and negotiation between July and September. The awards were announced at the end of September, and the funds were obligated by September 30th. Why September 30th, you ask? Because that's when the fiscal year ends, and so they had to get the funds out by September 30th. But this was really one of the most rapid processes leading to federal funding that I had ever experienced. And I want to give a tremendous shout out to the NIH staff who are working in the trenches making this happen, who are able to make this mechanism happen. And also, you see their really thoughtful fingerprints all over the application. And these are people who have elected to stay in a really difficult environment. They are doing God's work, and I am very grateful to them. So what could you do with this money? Well, first of all, you could not collect any new data. Any project that you proposed had to be using existing data sets. And you could focus on how do we use those kinds of data to study autism-related questions, because that's a complicated science in and of itself. You could look at genomic and what's called exposomic research. So exposome is a word that geneticists coined to call anything that's not genetics. Right? So any environmental factor, any social factor that might also affect health is in the exposome. You could use it to do traditional epidemiology, clinical and behavioral sciences, health services research, and implementation science. So that's what was in the notice of award. And I will say I submitted 3 applications in response to this. 2 of them were more services-oriented, and 1 led by the Children's Hospital of Philadelphia and Dr. Judy Miller was more causal related. That was the one that got funded. So you had to have a research strategy. That everything about this application was different than the traditional NIH. The font was different. The margins were different. Everything, it was almost like they wanted to make sure that whatever experience you had writing grant proposals to the NIH didn't count. And I think in some ways this maybe opened it up and leveled the playing field for people who didn't traditionally have that kind of funding. And they funded this under something called an other transactions mechanism. And this is one of the things, as Helen was talking about, got us a little concerned. It wasn't a grant, it wasn't a contract, it was an other transaction. Which we didn't know what that meant. They told us it meant that they could move more quickly. We took a breath and we jumped into the pool. You had very specific parts that you had to list. And here's where I was very excited to see those fingerprints of the NIH staff. You had to have a community engagement plan. This is very different than a traditional NIH mechanism. How are you going to involve various constituents of all types in your community in doing this kind of research? You had to have a resource sharing plan. How are you going to, beyond publishing in academic journals, how are you going to make the resources you created and your findings available to the community? And you had to have a really rigorous data management plan. All right, so I'm going to tell you a little bit about our study. I feel like there's a slide that disappeared. All right, because one of the things I wanted to show was where all the studies were that were funded. But anyway, there were 14 studies. There were 13 studies that were sites that were funded. 2 of them are data replication sites. And one of the things that was really different about this mechanism is you had to agree to share your data with another independent site so that they could replicate and validate your findings. Again, very different than the traditional NIH mechanism, and I think in response to some of the findings we are observing in the literature that go contrary to a lot of established research. There were 2 sites that focused on services and outcomes. So one at Oregon Health Sciences University and another at UNC. One focused on adult outcomes and what does an ideal adult trajectory look like for autistic adults, and another focusing on outcomes for youth. The other 9 studies all focused on something having to do with the effects of the genome and the exposome on outcomes. So a lot of gene by environment interaction studies, some of them in the Petri dish, and some of them using medical records and genomic data. Our study fell into one of those 9. So we have a lot of data that I'm going to tell you about that we can use to look at child factors, parent factors, genetics, the environment, clinical practice factors, and policies, and all their interactions that might lead someone to be diagnosed with autism. We wanted to do it in such a way that we could understand what part of the increase in prevalence in autism might be due to changes in the environment and what might be due to changes in diagnostic practice. We wanted to make sure that we engaged our autism community in Philadelphia to ensure that our study is consistent with their needs and values, and to ensure transparency. Because we were very concerned about the fact that we are using people's data, and in some cases they didn't necessarily give the data with this kind of study in mind, and that we could create an ongoing data resource for continued research. So what are we integrating? Well, I work across the street from the Children's Hospital of Philadelphia, which is the largest provider of children's health care in the Delaware Valley, excuse me. In the early 2000s, CHOP changed their policy so that they were regularly screening for autism at the 24 and 36-month visit. So we have 104,000 children on whom we have regular measures of autism symptoms. And so that's our denominator. And we have their electronic health records, so we can look at things like what other diagnoses they got, whether they got an autism diagnosis. And many children who receive services at CHOP have mothers who delivered within the University of Pennsylvania health system. So we can link the mother's data to the child's data, and in some cases we can link the father's data as well. And then we have a wonderful group of environmental epidemiologists who have been measuring at a very granular level, block by block, and sometimes address by address, exposure to various environmental contaminants. We have traditional ones like lead and other heavy metals. We also have measures of particulate air matter, air pollution, and things like that. So we can combine, now we know where the child and the mother live, we can combine that with that environmental data. And then I also have been studying policy and practice in the United States, but especially in Philadelphia and Pennsylvania since the early 2000s. And so we can look at how changes in policy and practice, for instance, an autism insurance mandate might change the rate of the diagnosis of autism. So those are the kinds of data sets we propose to merge to do this kind of study. And the way that we are proposing to do it is not unique. There are many overlapping data sets and strategies that we are using that are very similar to the other sites that are doing this work. So for our cohort, it will be those 104,000 children born in 2008 or later, all screened, excuse me, I gave the wrong month, screened for autism at 18 or 24-month well child visits, and they have at least one healthcare visit after age 4. Right, we want to make sure that there's some continuity of care, that we have some information about them as they age. From the electronic health record, we will extract demographic information, birth history, family history, and then all of the diagnoses they received, all of the different kinds of services and medical procedures they received, information about things like immunizations, the medications they received, and screening results for things other than autism. We will geocode their addresses and integrate that environmental data with the data about the child and the families. We know a lot about policies and practices, but we don't necessarily know how to turn them into variables that we can include in an analysis. So we'll spend a lot of time thinking about that. And we just got information or a suggestion that we might be able to integrate this with birth certificate data as well, which will tell us more about the mothers and also the fathers, like the parental age and occupation. So we can look at maybe environmental exposures they might have experienced as a result of their occupation. So we will use newfangled technology to analyze these data. We'll use machine learning and data-driven approaches. So this is often when we approach a scientific question, we have a hypothesis about it, and we design our study to test that particular hypothesis. And there are really strict rules in statistics about how you do that and what happens if you want to test another hypothesis as well that are very conservative in some ways. Machine learning is a very different approach in that it's not necessarily about, you don't have a hypothesis, you are looking at all your data together and you're seeing what associations might emerge. We will look at things like non-modifiable factors like age, sex, race, family history, and the more interesting aspect of our analysis, I think, will be in the non-modifiable factors, like, for instance, medications taken during pregnancy, air quality during pregnancy, for example. We can also do analyses where we use all 104,000 children in our sample, and there are some subsets, like, for instance, we might say among children who had some episode in the neonatal intensive care unit, what puts them at high probability of ultimately being diagnosed with autism? Or for the portion of the sample where we have really careful genetic data, can we do analyses there to look at gene by environment interactions? We want to look at what predicts a diagnosis of autism. We also want to look at what predicts things like autism plus a genetic syndrome or autism plus intellectual disability. I was very intrigued by recent findings that the genetics of kids who are diagnosed early with autism look very different than the genetics of kids who are diagnosed later with autism, and so we can do that in our sample. We can look at when they were diagnosed, in some ways as a proxy for the frankness of their symptoms, and see if that makes a difference in our predictive models. So will this reveal the cause of autism? No. It will reveal associations. Remember, machine learning is atheoretical, right? And it doesn't know from clinical plausibility. So there are some things, for example, that might be early indicators of risk, but not causally related. So if you had a NICU stay, and then you were later diagnosed with autism, that NICU stay didn't cause your autism, right? But it might let us know that for certain groups of children, we should be monitoring carefully very early on, thinking about intervention even before the full panoply of symptoms emerges. So even that is an important piece of information for us to have. What we hope to do is generate causal hypotheses that we can then test in future studies prospectively. And I will say, there's a joy of the ADSI in that we get to move quickly because the data are already collected, but there's also a problem with it in that the data are already collected, right? So there's no new data we're adding to this. These studies may be more hypothesis generating than anything else, but then allow us to prospectively collect data to test those hypotheses. And of course, we will be able to portion out what portion of the increase in autism seems to be environmentally determined and what parts of the environment are implicated. So we also could learn a lot of stuff, like what's the importance of addressing environmental exposures, whether different exposures lead to different types of autism, and the effects of policy and practice on observed prevalence, like answering the question, do we have an epidemic? We look forward to seeing how much our findings replicate across the other 8 sites that are doing similar work, and also thinking about how we might combine data across those sites to have even more nationally representative sample. This is the amazing team that's working on this study. I'm very grateful for the expertise that's represented there, from data science through clinical understanding of autism. Thanks.
Hi. So in your presentation, you mentioned one of your aims was engaging the autism community to ensure the study is consistent with the needs and values of this community. But this community, as you know, at times is very divided in terms of what those are. So how in your discourse and in that engagement do you convey that you're prioritizing good science, not junk science, good science, while also being delicate about not further alienating the community in your messaging?
It's a great question, a really increasingly important question. There is no one autism community at this point, right? There are people who are autistic, there are caregivers of autistic people, they have some shared values and concerns, and they have some really different values and concerns. Our community advisory board hopes to make sure that they are all represented, that those voices are represented at that table. So we have autistic people on our advisory boards. We have caregivers of profoundly affected people on our advisory boards. We have people from all socioeconomic groups on our advisory boards. We have clinicians and administrators, and we are not delicate, right? So we have a mission that NIH has given us with regard to this study, and we want to know that we start with, like, what are your concerns? What's keeping you up at night about this study, right? And just listening, pulling that information and saying, those are all great questions. How do we craft, like, a frequently asked question set of answers that we can make available to you, to the larger community? What concerns do you have that we can try and proactively address in this kind of study? And what questions do you have that we could answer with these data? And how would you want these results shared and used, right? And so that can guide that portion of it. We have a wonderful developmental pediatrician, Kate Wallace, who is very practiced in community engagement strategies, and she is leading that with a community member who is the co-chair of that community advisory board.
Hi, Debbie Hildebrand. Can you incorporate birth to 3 data for the 100,000 individuals that you've identified who've already come back to you at age 4?
Those data exist. Those data have data elements that would allow us to merge with the healthcare records. They are governed by a completely different set of privacy laws, the Federal Education Right to Privacy Act, as opposed to HIPAA. It is more stringent than HIPAA and makes it much more challenging to merge those data. So there are cases where that has been done. So for example, the CDC studies merge educational record and healthcare records. We did not have time in the short window given to submit the proposal to get those permissions to do that. I would love to be able to do that, and we are certainly pursuing that.
Hello, I'm Dr. Lisa Liberatore, founder of Love Michael. I want to ask if you considered looking at, of those 100,000, the siblings, and if there was any correlation difference that you could see between a sib that was either also diagnosed with autism or not, and if there was any difference in any of the other variables when looking at that.
So I love that idea. We have not proposed to do that, but we certainly could do that. And just, like, I don't want to give the impression that any of these analyses have happened yet, right? So we are we are still in the process of merging the data, which will actually take us much longer than doing the analyses. But that's a great idea, and it's certainly something I'll bring back to our team. I did not expect machine learning to be this popular.
Good morning. I'm Joe Joyce from the Autism Society, and I was just curious what the total amount was that was funded for these 13 studies, and also if the timeline for the studies is as aggressive as the application period.
Thanks for the question. The total amount, the total pot for this was $50 million, and I'm not sure how much of that $50 million was awarded, but I think it was pretty close to the cap. The timeline is very aggressive, so your study could be 2 or 3 years. The traditional, like if you applied for an R01, which is the traditional large research mechanism at NIH, those studies often are 5 years. So this is a much more aggressive timeline. All right, well, thank you very much.